In this second part of the GI lecture, we're going to pick up where we left off on the first part, talking about peptic ulcer disease. Some other disorders that will be covered in this part 2 lecture include dumping syndrome, oral cancers, esophageal cancer, and also stomach cancer. Peptic ulcer disease is where there's an actual ulceration through the protective mucous membrane into the inner wall of the stomach. There's a break somewhere in the mucous lining of the GI tract where it comes in contact with gastric juices. The most common causative factor is H. pylori. This affects about 10% of the U.S. population, which is around 4 million people per year that suffer from peptic ulcer disease. And it can be any area of the GI tract, anywhere from the stomach down to the duodenal area, which is actually the most common area that you find it. Some predisposing factors include if that patient is a type O blood type, if the patient has heavy NSAID use, smoking and alcohol use also, and stress and anxiety play a big factor as far as increasing a patient's risk. Here's an example of what peptic ulcer disease actually looks like. You can see in that right upper corner the actual ulceration that's in the gastric mucosa that can actually then lead to possible bleeding, erosion, and hemorrhage. So clinical manifestations are the patient complains of dull, gnawing kind of pain in the mid-epigastric to upper back area. They may complain of severe heartburn. Anorexia and weight loss are a couple other symptoms that are common. And they have this pain food relief pattern where a lot of times the patient has pain, eats, the pain gets a little bit better, but then 2 to 3 hours later the pain's back again and those types of things. It may wake the patient up at night and issues like that. Typically, peptic ulcer disease is going to be medically managed with meds such as antacids, H2 receptor antagonists, GI mucosal protectants, PPIs, and also antibiotics if the problem is actually from the H. pylori. So some lifestyle changes that are recommended are to decrease anxiety and stress, avoid alcohol and smoking, and especially watch diet, things high in acid and also caffeine intake. Some other nursing interventions would be to teach the correct way to use the medications. Try to have the patient use acetaminophen or Tylenol instead of aspirin or NSAIDs, and limit those dietary things like we talked about that are irritating to the stomach. Get regular exercise to help reduce stress and get the patients into anti-smoking programs. There's a good care plan in your textbook. Make sure you take a look at that. The page for it is listed in your speaker notes. Some complications of ulcers include the fact that the patient can hemorrhage, and if that happens, the symptoms are listed here. The patient may be vomiting up blood. They may have tachycardia, shocky symptoms with decreased blood pressure, decreased urine output. They may be very weak and dizzy because of poor cardiac output, and also go into hypovolemic shock. So important nursing interventions would be to check the H&H frequently. The patient will have no doubt an NGN, and they can have saline lavages to help control that, and also to keep a continuous O2 sat on it with frequent vital sign monitoring, and treat the patient for any shocky positions. Typically the patient will be supine or with a slight elevation at 30 degrees just to kind of help with the blood pressure and respiratory status. Another complication of ulcers is obstruction. The patient can actually develop scarring and edema, which can lead to gastric distension, nausea, vomiting, and anorexia, and feelings of that the patient feels full all the time and has electrolyte imbalances. So there's a picture to the right there of a patient that has had an obstruction within the stomach. So obviously this is going to be treated with a surgical management usually, and the patient will have an NGN. Another potential complication is the patient can actually erode. The ulcer can erode all the way through the entire stomach or duodenal mucosa into the abdominal cavity, and if so, that patient's at huge risk for peritonitis and a lot of complications. So if this happens, the patient typically will have severe sharp abdominal pain, absent bowel sounds, a fever, their abdomen will be rigid, very tender, board-like, and they will have symptoms of shock, such as tachycardia, tachypnea, very diaphoretic. So these patients need to go to surgery right away because they're at high risk for hemorrhaging out. And afterwards, it's going to be important that they're going to be on IV antibiotics and that they're going to have an NG in. So some other management ways to handle peptic ulcers would be different types of surgical procedures where they will actually take the area of the stomach that's ulcerated out, and then they'll connect the rest of the gastric stump to the areas of the duodenum or proximal jejunum, depending on what area of the gut is actually affected by the ulcer. Another thing is to have the patient have a vagotomy, which is where actually the vagal nerve is cut, and this helps to reduce gastric acid production. The patient may also need a pyeloplasty, and there's a good page in your book that looks at the nursing care plan of a patient having gastric surgery. This is a picture that just depicts the different Billroth procedures and a vagotomy and what actually is done in each of these different types of procedures. Some good nursing diagnoses or call for nursing after surgery. One would be high risk for impaired gas exchange. So the patient needs to have pain management, typically with a PCA pump or an epidural after these types of surgeries, and it's important to keep their respiratory function at the optimum. So get them up early, have them do incentive spirometry, keep a close eye on their pulmonary status. And as they're getting up and moving, always remember to splint that incision with blankets or towels to kind of help with the pain. Another nursing diagnosis for these patients is high risk for imbalanced nutrition. And for these particular patients with this problem, it's important to keep them on an NPO status and measure NG drainage and monitor for bleeding. You don't want to irrigate or reposition that NG tube unless ordered to do so, and notify the physician for any problems with it. Once they do have diet resumed, notice how they can tolerate it, watch for signs and symptoms of dumping syndrome, which we're going to talk about, and report any complications and bowel sounds. Knowledge deficit may be another issue, so gradually increase the amount of food so that they're doing small frequent meals, decrease the amount of fluids with meals, have the patient eat slower, and report any complications that they may have, such as vomiting, weakness, vomiting blood, hematemesis, and tarry stools, persistent diarrhea, and those types of things. Dumping syndrome actually occurs in about 50% of patients who've had surgery for peptic ulcer diseases, and that's due to a rapid entry of a large amount of food from the stomach to the jejunum that hasn't gone down or has not undergone a breakdown process in the stomach. Because remember, their normal route of food coming down the GI tract has been altered due to the procedure that they've had done. Another cause can be if the patient is taking too much fluid with their meals, and typically the patient will have these symptoms anywhere within 5 to 15 minutes to up to a half an hour to 2 hours after they're eating. And the symptoms of dumping syndrome include that the patient feels very full all of a sudden. They feel weak, faint, dizzy. They'll have tachycardia. They'll be very hypotensive. They get cramping and diarrhea, hypoglycemia. And once again, that's just due to that hyperosmolar chyme coming down into the jejunum too rapidly, which leads to an increase in blood sugar and causes the pancreas to increase insulin amount that's released, and that patient just gets hypoglycemic after the meal. This picture shows a diagram of what's going on with dumping syndrome and the signs and symptoms that patient typically has with this disorder. So some nursing interventions to help the patient with these symptoms would be to keep them in a semi-Fowler's after the meals. Perhaps have them rest on their left side for a half an hour after eating, and try to not put fluids with the meal, but rather have them do fluids either an hour before or an hour after meals, and have the meals contain more dry items than liquid items. It seems to be better tolerated. And just watch the concentrated carbs. If the patient's on some sort of oral liquid, make sure that if it is hyperosmolar, that it's diluted. So if that patient has like tube feedings or things like that. GI cancers are going to be covered next, and the first one we're going to start with our oral cancers, which include cancer of the lips, the tongue, the palate, and the floor of the mouth. A common cause is smoking and alcohol use. Typically, when we look at the stats on this, about 3% of all cancers in men and 2% of all cancers in women are oral cancers. The incidence is higher among African American men, and most occur in patients over the age of 45. First symptom is usually a painless lesion that kind of resembles a non-healing ulcer in the mouth. They may have red and white mouth types lesions in the mouth, and usually though they're not painful, those lesions are asymptomatic, and if that patient has a progression of these, they'll experience some speech and swallowing problems. This picture just shows an example of an oral lesion that's noted to be oral cancer. It's going to be diagnosed by biopsy and ultrasound and also CT to check involvement in other areas and tissues of the body. Radiation is typically used. There also is surgical excision, and if it's spread into the lymph nodes, that patient may need a radical neck dissection. It's important as far as interventions to watch for speech, chewing, swallowing, and airway problems, to give good mouth care, and to have that patient evaluated for diet and eating problems. So this cancer, unfortunately, is squamous cell carcinoma, which has a high rate of morbidity and mortality because it's not usually diagnosed until later and it has spread. Esophageal cancer can be anything from a benign to a malignant tumor of the esophagus. Once again, a common cause is smoking and alcohol use. One thing that's associated with this is Barrett's esophagus, which is noted to be tissue changes that respond to acid irritation over a period of months and years. This can turn malignant, and you'll see the patient have progressive dysphagia and abrupt weight loss. A lot of times, up to 90% of the circumference of the esophagus is involved before that patient starts to have symptoms. So once again, early diagnosis is sometimes doesn't happen, and the patient doesn't come in until the esophageal cancer has spread to quite a large area and those types of things. Management for this particular cancer is going to include chemotherapy, radiation, and surgery. And the patient may, most patients develop this type of cancer in the lower 1/3 of the esophagus. It's actually the 6th leading cause of death in men, and unfortunately it spreads very quickly to the supraclavicular lymph nodes and also to the liver and to the lungs. This slide just depicts the surgery that's actually done for esophageal cancer. It's the resection, and in the resection, the affected portion of the esophagus is removed, and then what's left is anastomose to the stomach with what little bit is left of the esophagus. So that's what it's showing there on the right. Nursing interventions for these patients after surgery is, of course, airway management, trying to keep the lung function to the best of that patient's potential. So turn, cough, and deep breathe, incentive spirometer, splinting the incision, PRN02, and if the patient has a chest tube in, watching drainage for that. Remember, anytime the patient has bright red and excessive drainage over like 70 milliliters per hour from that chest tube, the physician needs notified. Post-esophageal surgery, another issue is going to be nutritional support because these patients are going to be NPO for at least 5 to 7 days after this surgery. So these patients will probably need TPN and lipids during that initial NPO stage. And then once they're allowed to start eating, then those patients will have gradual introduction of oral fluids. So they can progress to pureed or semi-liquid diet with small meals once they tolerate that. So remember, we want to keep protein and albumin levels at a good level, so keep a close eye on those labs as well as daily calorie counts and daily weights. Complications of this surgery include infection, pulmonary problems, and you can actually have leakage at the anastomosis site. So the patient needs watched closely for these. And remember the psychosocial implications of this surgery also. So getting the patient hooked up with support services is important. These patients will come back with an NG tube in place after this surgery, and it's very important not to manipulate that NG tube. It shouldn't be repositioned. It should not be irrigated without a specific physician order, and that is to prevent tension or irritation on the suture line where that anastomosis is. So remember, just a small amount of blood may come out of that NG, but it should not be excessive. The physician should be notified if you start to get a lot of blood, because it could be that the patient's hemorrhaging out. So be real careful of that. If there's a lot of manipulation of that NG tube, it can actually cause leakage into the mediastinum. Cancer of the stomach, the risk factors are listed here. Could be genetic, environmental. Certain cultures are at higher risk. Could be also types of things in the diet or related to H. pylori infection. Symptoms are listed here. The patient may have very vague symptoms. They may not have any pain until late in their disease. A lot of times some early symptoms could just be anorexia and indigestion, some possible vomiting. It's typically treated with chemotherapy and radiation, and also by surgical resection where they remove all or part of the stomach, and then you do anastomosis of the duodenum or proximal jejunum. So with this particular cancer worldwide, it's actually the second most common cancer in the world after skin cancer being number 1, but it's not quite as common in the United States. So certain cultures that have an increased incidence would be the African American, the Hispanic, and Asian American culture, and it's much more common in men than it is in women.